Thank you very much. It was a pleasure to work with you, Alan. Right. Okay, I'm going to speak mainly about prostate cancer, although I thought you may be interested in some of the more recent work that we've been doing with people with high-grade gliomas. Okay, now, you may wonder what a picture of a jungle is doing right there. I wanted to describe the experience for people when they've been told that they've got cancer. They may have a map, in NHS terms it would be called a pathway, but that doesn't necessarily help them to navigate their way through the system. That doesn't necessarily help them to understand what decisions they want to be making, but there's an assumption that information by itself is all. And when I started working in the oncology service in the Western General Hospital in Edinburgh in 2001, I realized that there were an awful lot of patients coming through to my service that, in fact, that may have been avoided had they better understood the implications of the treatment and they weren't living in regret. There was one particular person who was referred to me with severe depression. It turns out that he was quite actively suicidal because for him the implications of being impotent were catastrophic. And although he did understand that information had been given to him about the risks of that, for him it was unacceptable. So people need a compass as well as a map, and information in itself isn't necessarily going to help them get there. So I started wondering if there was a different way in which we could do things. If we could stop and just think for a moment, could we do things slightly differently? So I think that Richard has described very articulately shared decision-making, so I'm not going to spend any longer on this particular slide because I think you've got the message in terms of that. Interestingly, when I run communication programs, shared decision-making just never comes up. It doesn't come up because I think people don't think it's a problem, and they don't think it's something that they have a problem with. And the concept of asking people for preferences doesn't necessarily seem to be something that people are wanting to understand how to do. So, like many good researchers, I borrowed somebody else's work. I went off to San Francisco, and I was really impressed by the work done by Jeff Belcora over there. He'd been working with breast cancer patients, and he had found that, in fact, by using this particular method, which is a kind of coaching method, that they had improved the patient's confidence about the decisions that they were taking about their breast cancer. So observing that system over there, I wondered whether we could apply it to Scotland. And of course, we were told there was no way that an American California model was going to work over here. And there were moments when I did wonder if they were correct. But in fact, this work was very successful. And I'm just going to go into a little bit more detail, but we identified that patients with this added decision support were less likely to regret the decisions about treatment, but also they were more likely to be confident and had less regret. Now, the most recent study that has just been completed is looking at the same model, but applying it to patients with colorectal disease, and both those studies are RCTs, and the study with high-grade glioma patients was qualitative, because thankfully there weren't enough people, you wouldn't want there to be enough people, to do an RCT in one centre. Okay. So this is the background, and this is what it is. The first stage of this model is about consultation planning. Consultation planning involves using a standardized and evidence-based kind of set of sort of a model. And we call it scoped. So we ask people to look at their situation, look at the choices they think are available to them, think of what they think may be the options, what their preferences are, and how they'd evaluate that. So how would they know that their decision is effective in what they're looking to achieve? So that could be done on the phone, or it could be done one-to-one. And it takes, on average, between 30 and 60 minutes. Rarely did it take anything longer than that. We then go on to the navigated consultation, where we have the navigator typing out the responses to those key questions. The doctor will have had that agenda beforehand, so they know what that patient is wanting to be asking them. And I must say that actually, before you're kind of thinking, oh my goodness, the idea of masses of information beforehand, the consultation plan was only ever 1 page long, so it's brief and it's to the point. And then the person has an audio recording of the consultation as well as that type summary. The type summary of the consultation, which again is very brief, it's just a couple of pages, was sent to the GP, kept in the medical notes, the patient had it to take away with them, and so they had the benefit of that personalised information. This is just an example of one of the consultation summaries. Okay, in terms of quantitative measures that we used, we looked at decision self-efficacy, and that's really to do with people's confidence about making their decision about treatment. Looking at decisional conflict scale, and that's the conflict, the concern that somebody may have about making a decision, and regret. And we measured that baseline after the intervention in 6 months. And we also looked at mood, looking at the a standard measure called the HADS measure. I'm sure that you're familiar with that. And we did a service evaluation to see what was happening. Now, these are the quantitative results. You can see there that decision self-efficacy, there were very significant changes at baseline and looking at after the consultation with the doctor, and that was sustained at 6 months. So if I can just remind people that the intervention is a really short intervention, and I think it's interesting that such a short intervention has a significant effect 6 months after the event. Decisional conflict scale, there was a significant result from baseline to post-consultation, almost significant, not quite, at 6 months. And here, this is the interesting finding in terms of regret. So we looked at those in the control arm, normal care, and we looked at those in the navigation arm, and we found there was a really significant result there about their experience of regret 6 months after the event. Interestingly, there were no differences in terms of mood or adjustment. Most people were very within the normal scale for mood, both and we checked this on multiple occasions as they went through the study. So perhaps that's why there weren't differences between pre and post. And this is the service evaluation. So you see here the kind of things that people were rating the study as enabling them to do. So in general, people felt that the intervention enabled them to make better decisions, helped them to organize their thoughts, enabled them to be more involved, to identify the key questions that were pertinent to them, and to help them to prepare. In terms of the qualitative data, this is interesting, that I think the prostate cancer patients have a really well-supported pathway, and the clinical nurse specialists are completely embedded into the system. And yet these patients tended to talk about not being able to ask vital questions and sometimes being not really prepared. And the navigation patients, again, similar kind of results there in terms of qualitative study as the evaluation. Some of the things that people said to us were, for instance, one of the control patients said, I didn't get the whole picture, it was like it was kind of skated over. He hadn't talked about the things like nerve sparing, I just felt like I was on a production line. And then, in contrast, navigation patients said, I didn't feel as if I was trying to tease information out of him. So again, you get the sense that people felt much more empowered to be able to ask the critical questions for them. The consultants with whom we are working, in the prostate team particularly, could really see the benefit of it and felt, generally speaking, that people seemed to be a little bit more confident in the consultations. That enabled them to be able to engage in a different kind of conversation because patients seemed to be so much better prepared. The GPs found this particular study to be particularly helpful. there was one GP who said, it's just so helpful not to look so completely blank when the patient comes in. So they found it a great relief to be able to have a conversation on a different level. They found the consultation summary particularly important because that often got to them before the letter from the clinic, so that they're able to have a conversation with the patient that was much more about what their real care needs were going to be. Okay. Now, the next stage of the study has been looking at people with conditions for which the treatment is only palliative. In terms of the high-grade gliomas, I'm not going to go into the colorectal cancer. There isn't time. So we used the same model, and we wanted to see what kind of impact that had. So instead of it just being a one-off cross-sectional study, which is what the last one was, this one was a progressive study. So people were seen at 3 consecutive occasions through their treatment plan. And again, the consultants found the intervention to be very reassuring, really. And they found that they were able to have again, a different kind of conversation with patients that enabled them to be much more confident that patients were going to be making the right decision. And actually just saying there that actually the consultation time, because that's probably what you're thinking about, did increase slightly, but it was actually only by about 2 to 5 minutes when we timed it. So in conclusion, I'd say that this intervention demonstrated that the particular study intervention did increase people's confidence and understanding and individualized their preparation for the consultations. And it enabled them to have a much better understanding of their treatment and the treatment decision-making. One of the key questions that's been posed to us is this sounds fantastic, but it's part of a study, so how do you make it part of normal care? So the next stage is we're going to be working with Macmillan staff to train them to be able to use this for all patients that either contact them through the helpline or through the Macmillan centres. And we want to see if the fidelity of this intervention remains as strong when you make it much more widespread. The impact is, I think we've just been talking about, and it's been great to see how clinical practice with prostate team has changed and how they're using, particularly the CDs, for consultations, and there's been really positive feedback on that. And we've also been working with Prostate Scotland with their information leaflets, and the neurosurgeons have also made some changes in the way in which they work with patients and been clearer about the outcome results. Now, this particular comic was taken for the BMJ. It wasn't from some kind of psychology journal. And it kind of describes, I think, what we're trying to achieve in terms of shared decision-making. Interestingly, the study that I've been running has had quite a lot of media interest. I think it's because it meets what people are asking for, as Richard was describing. And thank you.
So before Rob comes up, just to elaborate on that, having concluded this study, I thought with my colleagues, what do we do to take the good bits and get them embedded in practice? Employing a navigator wasn't really an option in the NHS. We have therefore worked with the charity, as Belinda said, Prostate Scotland, and we prepared booklets with them, and the patients within those booklets get making a treatment decision leaflet, which helps them prepare for the consultation. Working with our prostate cancer support group, we identified a company that could make or provide for us CD recording equipment that basically allows us to record a CD then and there. There's one copy, patient takes it away, and we've been doing that now for a year. We're in the process of evaluating that. And I think it's a bit cumbersome. It adds a little bit of time to our the clinic consultations, but my view is that these people are going to live for a long time with the consequences of their treatment, cured or not. So it's really important that we get it right for them at the outset. And a bit of time spent making the right decision will save an awful lot of time dealing with an unhappy patient who's living with the regret and disappointment and outcome of their treatment. So it's well worth making the effort.